My name's John Ford. I'm a clinical lecturer at the University of Cambridge, and I have a split post between the university and I've been working in Cambridge and Peterborough CCG, where I've been leading on health inequalities. And so this work comes from my Cambridge and Peterborough CCG role, but my research interests are in health inequalities as well. So in this kind of talk, I want to focus on inequalities or I guess healthcare inequalities specifically. And just to say, I think there's lots of different ways health systems can address health inequalities. So there is the advocacy and the influence side of stuff. There's um, healthcare organizations as employers, so the whole anchor institution stuff. And then there's provision of care. I'm going to focus on that last part, but we can talk about anchor institutions or advocacy influence if helpful later. And in this next few minutes, I just want to set out two challenges, two consequences, and then two solutions that we've developed locally. I'm not claiming to have all the answers, but I'm just going to share our experience. So first of all, two challenges. The first challenge I think we and I faced was really a lack of consensus about what health inequalities are and what they aren't. My experience is that when I speak to people in the healthcare system in Cambridge and Peterborough, for some people, health inequalities means differences between rich and poor, differences in life expectancy between rich and poor. For other people, it's all about minority ethnic groups or LGBT plus groups. For other people, it's about inclusion health, about homelessness, gypsy Roma traveller, or learning disabilities. And so it then meant that, or means that health inequalities tends to be used all over the place to mean lots of different things in quite a vague way. And so a lot of the NHS documents I've seen use health inequalities, the term health inequalities, quite casually, without a lot of meaning. I think the second challenge and consequence is that people don't know what to do about health inequalities. There's this uncertainty. And while we could all agree around some of the big geopolitical stuff to address health inequalities around income and education and employment, actually think about what the NHS can do becomes a little more difficult. I think the consequences are that there's this paradigm of fatalism, fantasy, or flamboyancy, is what I've said. I'll just talk to you about what I mean by each of them. So first one's the paradigm of fatalism. So I find this, particularly if you start off a conversation around differences in life expectancy with NHS decision makers, policy makers, practitioners, that can sometimes lead to this paradigm of fatalism of, well, what can I do to address the gap in life expectancy? And actually, it leads to actions which aren't particularly effective. Second one's a paradigm of fantasy. So I guess I've seen this where I guess health actions or there's this widespread belief that health inequalities are going to be addressed through one or two key health actions. So it might be, for example, social prescribing. So I think there's completely a place for social prescribing. And I'm not bashing it in any way. But actually, if that becomes the way that the system's going to address health inequalities, then actually I think that's fantasy, because there's much bigger influences on health inequalities rather than just what social prescribing can do. And it tends to happen when they're specifically downstream individual actions like social prescribing rather than upstream factors of funding and workforce, for example. Or else there's this paradigm of flamboyancy. So I guess I see this when certain groups aren't focusing on the healthcare inequalities here and now. So inequalities in workforce, funding, patient experience, secondary care use. So they overlook all of that and just jump to quite outlandish ideas. So the one I heard recently was setting up a joint fund with Amazon to do some workplace health promotion activities, which in itself, might have utility, but actually, if you're not addressing the core inequalities in the system and jumping straight to things like that, then I think that's an adverse consequence. So a couple of things that we did. So two solutions. One is trying to clarify what health inequalities are. So we're really clear that there's a difference between health care inequalities and health outcome inequalities. Health care inequalities are the things that the NHS is very good or has a lot of influence and responsibility over. So that's inequalities in whether it's patient experience in primary care or meeting treatment targets or elective care, so kind of health care inequalities, as well as the system things of funding and workforce. Health outcome inequalities in terms of differences in cardiovascular mortality. Well, yes, the NHS can influence them, but it's usually indirectly through healthcare inequalities. And actually that needs a much wider partnership approach to addressing those health outcome inequalities. And secondly, we tried to produce a systematic way of looking at health inequalities. So we created these three groups: socioeconomic groups, disadvantaged groups, and inclusion health groups. Again, just to give people a framework to think, well, when we're talking about health inequalities, we can think about it in these three different ways. Again, to try and to help add some flesh to the bones. So that's about clarifying what health inequalities are, and then what to do about it. We knew that one intervention wasn't going to cure inequalities, so we made a lot of effort to try and increase the maturity of the system in terms of health inequalities thinking. That started with leadership and culture. So we've got a strategy and an action plan. We've got a health inequalities board. We developed some guiding principles, which we've been embedding into the organization around service delivery and development. We focused on funding, so we developed a formula to weight discretionary local funds by IMD. And then we had two process actions, one around impact assessments, about trying to improve the equity of decision making, and one around equity audits. Again, all to try and develop the thinking and the culture within the healthcare system. So I think I'll stop there, and we'll open it up to questions or comments or discussion.